a long time ago, 2019.
Very careful with your head.
Was last meeting in Lyon, and at that time, like going to this work and the consortium, it was baby steps. So we were just starting this activity, and it's very difficult to believe that the first publication that really changed the approach of the management of CMMRD was in 2015. So that's 7 years ago only, and so much has been done. I think in particular thanks to the enthusiasm of Dr. Sabori, but also many people, including you, and all the members of the consortium. And here we are today without Uri, unfortunately, but I don't know if he's going to connect, to have an update and really a discussion also, and to try to figure out where we will go next. So to really make this meeting, which is going to be a 1.5-hour meeting, lively and enthusiastic. We have a number of speakers first who will present some update on CMMRD, and we have also sort of roundtable where we want in particular to address the challenge of CMMRD around the world. So the speaker in the session this morning will be Anya Van, Brian, here, and Yana. Am I wrong?
No, you're right.
And Vanessa, about the CMMRD consortium. So without any delay, so we start, and so that's going to be.
So it will start and then we will start.
Okay, and perhaps people should introduce themselves. Please, know you. I don't know, Regina and Margaret. So very quickly, 1 minute, 40 seconds, 10 seconds.
All right, so sure. Hi, everyone. I'm Lucy. I'm the biobank manager for the IRRDC.
Hi, everyone. I'm Vanessa Bianchi, and I manage our international consortium.
Hi, my name is Brian. I'm a research fellow for the consortium.
Hi, my name is Ayurban. I'm a pediatric neuro-oncologist working in the consortium.
Hi, my name is Yana Nobre. I'm also a pediatric neuro-oncologist.
I'm Virginia Kibudi. I'm a pediatric hematologist oncologist at Istanbul University and happy to be working in the IRRD consortium.
As Montassa Nayedi, pediatric neuro-oncologist so the cancer hospital, and I'm happy to join the consortium.
And so we have also hopefully folks speaker online.
Yes. Yeah, so we have some panelists online as well, and I think I'll let them introduce themselves later on when we get started. So without further ado, we will go ahead. So good morning, everyone, and welcome to the International Replication Impaired Deficiency Consortium educational session. My name is Lucy Stengs. As I said, I'm the biobank manager for the IRRDC, and it's my pleasure to moderate today's event. So today represents an incredibly important milestone for us, coming together of physicians, scientists, collaborators. And we thank you for joining us to discuss the phenomenon that is replication repair deficiency, our updates on consortium, treatment and diagnostic strategies, and our ongoing efforts to mitigate healthcare disparities between high, middle, and low-income countries. On the screen behind me, 1 second. You will see the agenda for today as was distributed to you all by email. You'll hear 4 talks, as Eric mentioned, first from Dr. Vanessa Bianchi, then Brian Chung, then Dr. Anna Van Das, and Dr. Liana Nobre. And then, as Eric said, there will be a panel discussion with our representatives from the LMIC. So they're coming from Pakistan, India, Turkey, Jordan, and Egypt. So in order to save us some time and avoid some redundancy, I'm going to quickly explain some very basic concepts to you that I'm sure you're all familiar with. So to start, I just want to introduce what is replication repair deficiency. So many of you probably know this as you have treated or diagnosed patients with this condition. But replication repair deficiency is an umbrella term, and it describes loss of functional DNA replication repair. And it can be due to a germline predisposition, as with CMMRD, or constitutional mismatch repair deficiency, or it can be a completely somatic event, but that is much rarer. Generally, when patients have replication repair deficiency in their tumors, we can identify an underlying predisposition in the germline. There are 2 complexes that play a role in correcting DNA replication errors. Welcome, coffee. Please also feel free to help yourself. I know that's part of the thing of a breakfast meeting, so please don't feel rude, just go and get stuff. But yeah, so there's two complexes involved, the mismatch repair complex, which is made up of MLH1, PMS2, MSH2, and MSH6, and then the polymerase. And when DNA is copied each time a cell divides, there are errors inherently made in the sequence, and wrong base pairs can be inserted. So when that happens, it is the job of those two complexes to repair those errors. However, if either or both of these complexes have mutations that alter or impair their function, then the cancer or the patient can be replication repair deficient. So because of our collaboration with physicians internationally, we've been able to form a comprehensive registry of CMMRD patients, which has allowed us to study things like the tumor spectrum. What we've learned through these collaborations is that patients with replication repair deficiency will develop a myriad of tumors throughout their body at a young age. And what the figure and statistics on screen are showing is specific to our CMMRD cohort. But these types of the spectrum of cancers that we see are common across the entire umbrella of replication repair deficiency. I'd like to highlight as well that we do see adult type cancers like breast, endometrial, and prostate cancer in young children. And what is critical for these patients is that they must undergo surveillance in order to identify and catch these tumors early. And this is a very important aspect to saving lives. Our consortium also receives and consults on a lot of cases that can be classified as what's called pediatric Lynch syndrome, where the germline is heterozygous, but the tumors have acquired a secondary somatic hit that infers homozygous mismatch repair. In addition to this, we also see polymerase epsilon and polymerase delta mutations, both in germline and in tumor. And these are all classified under our spectrum of replication repair deficiency. I hope that's clear.
Recording in progress.
So because of the mismatch process repairs all DNA replication errors, which includes length changes that occur in microsatellites. So you may be asking, what is a microsatellite? It's simply a short repeat sequence of DNA, and these occur at thousands of locations throughout the genome. They can be a single base repeat, such as AAAAA, or it can be a pattern of two or more bases, CG, CG, AT, AT, etc. We call these length changes indels, insertions, deletions. And when mismatch repair is dysfunctional, these length changes in the microsatellites are not repaired. And as such, the cells acquire what we call microsatellite instability, or MSI. Here you can see the microsatellite has increased from 7 repeats to 6 repeats in an MMR deficient cell. Dr. Brian Chung, who you will hear from today, has invented an effective bioinformatic tool that can classify a cancer as replication repair deficient using these indel signatures. And he can detect this even through ultra-low whole genome sequencing. The resulting diagnostic tool is low cost and very powerful, and we hope to convince you that you should be implementing this at your centers. Final concept I'll go over is immunotherapy. So finally, our research on replication repair deficient cancers suggests that genomic biomarkers such as tumor mutation burden, or TMB, measured mutations per megabase, and MSI can both drive immune response to immune checkpoint inhibitors. This is based primarily on the tumor cell antigen load, which stimulates a cytotoxic response from infiltrating T cells, whereby immune checkpoint inhibitors, such as anti-PD-1, can sustain that response. Dr. Anirban Das and Dr. Liana Nobre will build a case for this using their evidence of these biomarkers in their clinical and research cohorts. And Anirban will tell you that even if you fail anti-PD-1, then there's still more that you can do. Liana will then focus on identifying novel techniques to monitor these ICI responders. Without further ado, I'll push it over to Vanessa to tell you about our consortium.
Okay, so coffee has arrived, so if the people in the room want to get up, you guys can go ahead and grab yourself something. Just a note to our people at home to please keep the microphones off so that we don't have any feedback. That would be amazing. All right. So I know I briefly introduced myself already, but thank you everyone for joining this meeting. If we have not met before, my name is Vanessa Bianchi and I manage our International Replication Repair Deficiency Consortium, which focuses on syndromes that cause DNA replication repair. And I've had the privilege of working with these wonderful clinicians and scientists for a few years now, and they do some really amazing work, and they're going to share some of that with you soon. But before we get into that, what I want to do is just introduce the consortium, who we are, what we do, how we work with clinicians and scientists like yourself. And then at the end, I'm going to circle back and tell you about how you can register a patient with us and what's involved in that. So as Eric said, Dr. Uri Tabori is not with us today at SIOP, but he started the consortium in 2008 with some of his colleagues. And he created a patient registry and a biobank for individuals with replication repair deficiency, with the overall vision of improving care for individuals with these types of cancers and with germline predisposition. This consortium would also enable us to help clinicians globally. We are now collaborating with over 50 countries, and we have a vast registry and biobank that has enabled many discoveries and transformed the way that we care for patients. And so just a note that when you reach the consortium, who you actually reach is usually myself. I'm one of the first people you're connected with, as well as Lucy, who just did the introduction today. So it's really great to actually see some of you who we've worked with before in person and speak to you today. So as I've said, we have patients and collaborations from all over the world, and this slide is really just a visual representation of that. But I think what's important is that you can see that our patients come from countries of various income levels. And we work very closely with many low and middle income countries, which may not have the same resources at their disposal that are available to us. And this is really where I see the clinical aspect of the IRRDC make an impact on patient care globally. So when a patient is referred to us, it's generally based on either suspicion or identification of replication repair deficiency, and they're generally connected to us by their physician, and we always work with their local care team. So if a patient comes to us on their own, which does sometimes happen, the first thing we do is connect to their local team. And just to go into some of what we do, the consortium holds weekly rounds to do things like view MRIs or discuss patient care when a consult request comes in or testing comes back to us or feedback is requested. And this is always relayed directly back to the physicians and the healthcare team locally. We also perform clinical and research testing in-house, which may include things like pathology reviews, biomarker analysis, molecular analysis, our functional assays, as well as some other testing depending on the type of cancer or the question that's being asked. And one of the things that we also do is consult with our RRD expert genetic counselor, Melissa Aronson, who has established diagnostic criteria for replication repair deficiency. And this is really important for us, especially when a diagnosis has not yet been confirmed or may not be completely straightforward. And so these are some of the ways that we can work with you on patient care globally. So now to what to look for when considering whether a patient is replication repair deficient. Any or a combination of these characteristics that I have listed here should warrant a discussion. So things like cafe au lait macules, which are not exclusive to replication repair deficiency. However, when we've looked into our bank, you can see here that our patients, the vast majority do have cafe au lait macules. And so in combination with other factors like consanguinity, a family history of RRD type cancers or spectrum of cancers, young gastrointestinal cancers in childhood, or if you see things like synchronous or metachronous cancers, the presence of cafe au lait macules may indicate suspicion of RRD in these cases. One of the other things I want to highlight is suspicion of NF1. Over 20% of the patients in our registry fulfill the criteria for NF1. And we do sometimes see patients that are initially misdiagnosed with NF1 actually being CMMRD or other replication repair deficiency. So I think in combination with some of these other characteristics, this is also something that we should look for. There are a number of molecular characteristics in the cancers as well. So if this type of information is available to you, things like hypermutation or ultra hypermutation, Getting reports back where you see many variants of unknown significance, of course, high single nucleotide variants being reported, or the presence of mismatch repair or polymerase variants, either in the germline or somatically, may indicate that the cancer or the patient may be mismatch repair deficient. And finally, one of the last things I wanted to just highlight is something that we commonly see in the consortium that I don't think is highly reported, and that is developmental venous anomalies in the MRI brain scans of patients with replication repair deficiency. So with respect to prevalence, syndromes that cause replication repair deficiency are often thought to be quite rare. However, we haven't truly been able to assess prevalence on a global level. We know that replication repair deficiency is enriched in cancers that are hypermutant, and you can see that here. This is a study that we did with a Foundation 1 cohort. However, we know from the work that Eric and many of our collaborators here have done globally that in countries where consanguineous marriages occur, for specific types of cancers, IRRD or replication repair deficiency can be as high as 40%. And that is what we see for pediatric high-grade gliomas in India and Jordan, and we've reported on these previously. And so you're going to hear more from Eric later in the panel discussion. What we do hope, though, is that with the development of new diagnostic screening tools for replication repair deficiency, we can get a better sense of the true prevalence. And Brian, who you're going to hear from later today as well, will be telling you more about this new tool that he's developed in our group called Logic. So I want to switch gears for a minute and talk about how we collaborate with physicians globally on research. Firstly, we're always open to new proposals, which may seek to utilize clinical information or biological samples from our biobank. And as part of our consent process, patients can sign to share their de-identified information or samples with other investigators. So if you wish to work with us on a project, we invite you to submit a proposal for review by the governance committee, who you can see up on the screen here. And generally, as long as there's no competing interests or concerns, the proposals are passed relatively quickly and we can start sending you information or samples or whatever is needed to complete the project. Currently, we have over 20 projects that are ongoing with external collaborators. And we've also published more than 30 publications since the consortium started with external and low middle income country collaborators. And what I wanted to highlight about these is that these collaborators are acknowledged as first or last authors on these manuscripts specifically. So what we really wish is for our biobank and registry to be collaborative, because we know that this is the best way to help patients and advance discoveries in the long term. So in addition to our collaborative projects, we have researchers internally that are doing some amazing stuff. And of course, we always acknowledge external collaborators as well on these projects if they've contributed patients to our registry. So our registry and bank now is almost 15 years in the making, and it has enabled many discoveries that are transformative in the care of patients with RRD. And none of this could have been possible, of course, without the support and help of our collaborators who have joined our registry with us. So there's obviously still a ton to do, but we've made some amazing advances in things like cancer prevention, therapies for replication repair deficient cancers, and you're going to hear more from that from Dr. Das, as well as things like novel biomarkers and signatures that can predict response to therapy, and that's along the lines of what Dr. Liana Nobre is going to talk to you about later today. So just to conclude why we do what we do, this slide is just a picture of some of our patients from the international consortium. Of course, they were provided with consent. And really, this is the reason why we keep trying to advance discoveries, do research, and work with collaborators all over the world. And so what I'm going to do is I'm going to hand it over to Dr. Chung now, who's going to talk to you more about his new novel diagnostic tool to help identify replication repair deficiency. So Brian, I'm going to get you to sit over here so that you can have the camera and microphone on you. Thank you guys so much. I'll circle back at the end to talk about how you can register a patient with us, what's involved with that, and what's next for the consortium after all the other talks are done. Thanks.
Hello, everybody. My name is Brian, and I'm really excited to be here with you to share what our new diagnostic tool is all about. And just want to emphasize before I start that this is everything here that I'm showing is truly a collaboration between the consortium as well as the Broad Institute. So really, you will see how everything that I'm going to talk about really is a big international approach. So what is LOGIC and what is this fancy name? It's actually just an acronym that we call Low Coverage Genomic Instability Characterization. This tool is remarkably simple, actually, the pipeline or the workflow. It takes samples that can be embedded in paraffin or frozen tissues. We extract the DNA, send it for low coverage sequencing, and we apply bioinformatic algorithms to yield multiple types of different mutational characteristics for each sample. Some of these examples that we can get are MSI or microsatellite instability, which is important for the diagnosis of replication repair deficiency, as well as tumor mutational burden, mutational signatures, which are also important for diagnosis, but also very important for treatment, for immunotherapy, and CNV or copy number variants, which drive all types of different cancers. And we can all get all this information from one sequencing test at low coverage. I'll be mostly talking about the MSI portion, as that's been the focus of my project. And one last important thing to remember is that this test per sample is around 125 to 150 Canadian dollars, which is extremely cheap to get all this information from. So using microsatellite instability as a way to diagnose replication repair deficiency, we tested over a cohort of 170 cancers shown here on the left, and we achieved very high sensitivity and specificity. You can see on the y-axis also that it's actually a scalar or quantitative score. So it's not just a yes/no diagnosis of binary, but rather we can actually test for the magnitude of the microsatellite instability in each sample. And when we compare the sensitivity of this tool compared to other tests that are routinely used for detection of replication repair deficiency, we find that compared to tumor mutational burden and immunohistochemistry, which are routinely used, it achieves a higher sensitivity as well. And compared to the older system of the microsatellite instability analysis system called the ProMega panel, it really does not work in pediatric tumors. So using LOGIC, we are able to detect them because it expands the number of microsatellites that we can analyze in the whole genome from 5 loci, which is the old way, to 23 million microsatellites in the whole genome that we analyze. And using this as the basis of the strength of this tool, we're actually also able to analyze unmatched tissue. What does that mean? It means that we don't need to do tumor analysis with matched normal tissue to get one mutation, one mutational characteristic. That is the case for tumor mutational burden, where you need tumor and the blood to call the mutations. However, using 23 million microsatellites, again, we're able to analyze the tumor and the germline separately. So that enables us then to do germline testing or germline analysis of the microsatellite instability. So that's what you see on here on the left, where you see in constitutional mismatch repair deficiency or CMMRD samples, you can see that it's all above the score of 0. That means that it has a lack of mismatch repair activity. And all the other samples that we have, which include other replication repair deficiency subtypes and other pediatric cancer predisposition syndromes such as Lipomany and NF1, they all score under 0 because they have functional intact mismatch repair activity. Another important thing to note on the right here is that this tool is very resourceful in the way that it can use even degraded saliva DNA that's being shipped from all over the world. So here on the right, you're using a pilot cohort of CMMRD individuals. We just take some saliva samples, extract the DNA, and we can also see that the LOGIC score is able to pick up on the lack of mismatch repair activity, even using this kind of DNA. So it's very accessible, very easily implementable, particularly in LMIC. So one of the applications that we can use from this diagnostic tool is you can also see that even though CMMRD individuals, they all have a very high score, there's actually quite a large variance. As you can see, if there's some dots over here and a cluster of dots happening on the bottom. So we asked the question, what is going on and what can we do with it? So why do some patients score so low and why did they score so high if all of them are supposed to be ablated for mismatch repair activity in every cell? So interestingly, when we correlate the score on the y-axis here with the age of first cancer diagnosis, we actually can find that older patients are the ones who scored lower on the previous slide, and the younger patients actually score higher. So what this and then enables us to do something called assessment of risk of cancer onset using the logic score. For example, under the age of, let's say, 19 years old, we do not have any individuals who have a score of less than 0.015. So what we can say is that if an individual comes who is 10 years old with that score that's under 0.015, that person or a patient is at a lower risk of cancer than a person who is at the same age, a much higher score, or much older at that score. So although we did say that cancer surveillance does save lives, it is quite intensive for the patients with multiple MRIs and other things. So really what we can use, we can just do a simple blood test and actually tailor the surveillance protocol so it starts at a more appropriate age at when the cancer risk is higher in those patients. Another problem that we were able to solve using the logic score in the germline is that because CMMRD individuals, they can have various types of mutations that occur, such as they're pathogenic, likely pathogenic, variants of unknown significance. You never really exactly can tell right away based on just the mutations whether that person has CMMRD. So the important thing that I need to emphasize is that this is a functional assay. What that means is that it measures the phenotype of the lack of mismatch repair activity because it measures the mutational landscape or mutational magnitude of the microsatellites. So by assigning a score that is quantitative, we can solve these, and we have already solved many difficult cases in the consortium using this tool. We can solve cases that have a mix of drivers and VUSs, for example. So what you see up here in the slides is that there are 7 examples of cases that were difficult to solve with mixes of variants of unknown significance. We were able to use logic to be able to determine that they have lack of mismatch repair activity in the germline. Now, I want to tease you a little bit on what Dr. Das is going to speak about. So we talked enough about germline. Just to go back to the tumors, the logic score, there's another aspect of it called a Paul-Enis score. The names are kind of funny, but so the funny thing about that, interesting thing about that we can do using the Paul-Enis score is that it can also predict response to immunotherapy. We know that immunotherapy is highly effective in these patients, but not all tumors respond. So using the Paul-Enis score, we're able to, again, generate a predictive marker for immunotherapy response, and they yield higher survival, shown on the right as well. And now to conclude, just want to tell you about the impact that this tool can have on the diagnostic landscape. And I just want to give a little bit of background just in adults before I move on to children. So in adulthood cancers, just in Canada, we have in colorectal and endometrial cancers, we do routine screening to look for mismatch repair loss, and it can actually cost quite a lot of money, up to $4,000 per test per patient. Using the tool that I said that only costs $125 to $150 Canadian, here I did a little bit of a conservative estimate of $250. We can actually see estimates of savings of up to $15 million per year in the healthcare system, and still get the right diagnosis and still to give them appropriate treatments and surveillance and therapy. And now in children, in Canada, screening is not really existent for replication repair deficiency, but with logic being such an implementable and wide-scale tool, we can definitely implement this quite easily in the clinic, into clinical use. And the opposite problem here is that we're missing cases of replication repair deficiency in children, which we estimate to be upwards of 10%, because we do not have screening protocols in place. So using logic for tumor and for germline, we'll be able to give the right therapy, the right cancer surveillance, and the genetic counseling that these individuals need. So just to conclude, I just want to emphasize again that logic is a cheap tool to screen that can be used to screen and diagnose replication repair deficiency. It's very easily implementable. It has very low tissue requirements. It can do as little as 100 nanograms of DNA from paraffin, which we have validated multiple times that it works. So the future directions of the tool is to use this as a screening tool for RD in cancers, germline diagnostic tool for CMMRD in children, as well as to predict risk of cancer surveillance to tailor the surveillance protocol for the patients. Thank you so much for your attention, and we would love to just come talk to us to talk about collaborative opportunities. Thank you.
Brian, before you go, we have time for one question.
Oh, sure.
So one came to me in the chat, which was, how can I implement logic on my sensor? So I guess coming off what I said.
Yeah, I think that's the chat bubble.
Yeah.
Yeah, so the logic tool, really, it's DNA extraction is, I think, a widespread, and any center can do. The sequencing part, there are multiple options for next generation sequencing platforms. I think that part is something that we actually need to discuss a little bit deeper. But there are next generation sequencing platforms that can be used clinically that is not too expensive. We use Illumina, the NextSeq and the NovaSeq platforms that we have in SickKids. But definitely we can also send us samples to sequence. We have received samples from all over the world. Actually, everything that I've shown are samples that we've collected internationally. So if there's anything that you want to run or analyze, you can just talk to us and we can even sequence it for you. That's good. Thank you.
Thank you, Brian. Firstly, it's a privilege to be in front of you today and share what we are sharing today. So thank you for being here. So my name is Anirban and I will be talking about what we are doing with immunotherapy for our children with IRRD cancers. So as all of you know, and Lucy also presented, that glioblastoma is per se a deadly cancer. In the context of IRRD, it's even more so, and our published data with all of your help shows that the median survival with chemoradiation is only 9 months. And once they recur, almost everyone dies. There are no survivors at 1 year. Lucy also told you about synchronous cancers. So we have around 25% of our patients with CMRD. You can see here a patient presenting with colon as well as glioblastoma. So it's deadly, but we also learned that these cancers uniformly have high TMB and high MSI, which provided Dr. Bouffet and Dr. Tabori with the opportunity to try immune checkpoint inhibition. And I'm sure all of you know, but just to sort of rehash, that the tumor cell is an abnormal cell, the antigen should be recognized and the T cells should kill them off. But that doesn't happen because there is a negative interaction that prevents this from happening. And when we block that by using chemotherapy, immunotherapy agents, they can actually allow the T cells to kill off the tumor cells. And that has been shown in many refractory adult cancers with high TMB and high MSI, including lung, melanoma, and colon cancers. So our global registry study on 45 tumors showed that we did see with anti-PD-1 impressive response in the waterfall plot. You can see the positives here and the negatives here, including responses in glioblastoma. And patients with deadly tumors who, as you saw, died within a year at recurrence on treatment with anti-PD-1, swimming for more than 4 years. Now we have more mature data on more number of patients, thanks to you. And for 75 glioblastomas, we now have a median survival of more than 2 years, which is better than the progression-free survival statistically as well, suggesting that immunotherapy is not a one-time thing, and I will be coming back to this in my later slides. I talked to you about synchronous cancers, and most of these cancers are driven by the same biological mechanism. So you can hit 2 birds with 1 stone, and the same patient with metastatic colon cancer or glioblastoma, the metastatic and the primary sites almost disappearing completely, and the glioblastoma staying stable for more than 3 years in this particular patient. So TMB and MSI we heard about today as well, and those are important biomarkers because what happens is that these cancers with high TMB and high MSI have high neoantigen expression, and that makes even tumors like glioblastoma, which are usually T cell poor and more CD8 macrophage rich, become CD8 rich. You can see the black, brown dots over here. And these are important biomarkers that we described in our first paper. And just to show that tumors which have both like high genomic markers like TMB, MSI and high immune markers, even at recurrence had around 80% survival with PD-1 inhibition. So Liana will be talking about the more novel biomarkers, but I just want to share that we do all these biomarkers for all of our patients in the consortium. And this really helps us in the consortium tumor board meetings to decide which patients will actually are more likely to respond and plan ahead. The other important point is about the best responders that I showed you in the last curve. We all treat children and we know that radiotherapy is pretty toxic, chemotherapy as well. So for this particular subset of favorable biomarker tumors, we were able to treat such children with good surgery. And once we confirmed that they were good biomarkers, treat them without radiation, without chemotherapy, with anti-PD-1. And we have an enlarging cohort of these patients who are doing well. So very selected subgroup, but a subgroup that we can probably benefit long-term, in addition to having short-term benefits. And right now we are planning a clinical trial, including countries from LMIC, and we have received some grants and we are still approaching some other agencies for grants to make this happen in the next couple of years. So moving on, sometimes what happens is that the tumors can actually have a hyperimmune reaction. And some of you actually may see that, and we have sort of consults from across the globe when that happens. And we also have biomarkers to detect that. Sometimes when the biopsy is done, we can see that there is high immune infiltration. But more importantly, we are identifying biomarkers in the blood, including high levels of 4-1BB positive activated T cells, which can tell you in the backdrop of the cancer genomics that, okay, this is a tumor which is likely to respond. There are activated T cells in the blood, so this is not true progression, this is likely pseudo progression. And in the consortium, we can actually do central review of not only the radiology, but also the biomarkers and take a consensus call with our physician colleagues to make sure that we are not stopping treatment early. Because once you continue treatment for these patients, they have delayed response and prolonged survival. The other unique aspect that we are learning while treating patients is that immunotherapy is not like chemotherapy or even radiation. And sometimes the responses may take time, especially because maybe of the blood-brain barrier, or because it's like glioblastoma that requires more time, or maybe because the tumors are continuing to accumulate mutations. Sometimes we see true progression. So this was a young patient who was continued on trial for almost 4 months, but the tumors continued to progress at multiple sites, was sent home on palliative care. And when we followed up 6 months later, without any treatment in the interim, the tumor had almost disappeared. We called the patient back, restarted her on immunotherapy, continued for 18 more months, and she stopped actually treatment in April this year and is alive and well right now. So delayed responses, even after sustained initial progression, can happen. And we may try to hypothesize why this may happen. And we actually saw that in one patient where we actually did the biopsy at this point of time when there was continued progression. The tumor, which had relatively lower, like it's still high TMB, but lower than what it is at progression. And similarly, the immune infiltrates, which were not there at all at baseline, were more at the time of progression, and on continuing of immunotherapy, there was again delayed response. So this is important to understand that in the context of germline genomic instability, these cancers may continue to accumulate mutations. So we may need to be patient before saying that, okay, immunotherapy has not worked. So this is what I was coming to, that in contrast to cytotoxic therapies, which we are more comfortable with, immune activation is usually durable. And here you see that patients who stopped immunotherapy prematurely, maybe because we didn't know at that time, had an inferior survival, whereas if we have really tumors with good biomarkers and we use immunotherapy in combination with other forms of checkpoint inhibitors or targeted therapy or even re-radiation, we can really prolong survival in these patients. And just to highlight that this is the time point from second progression, so progression on anti-PD-1 after that. So another insight that we wanted to share is that many of you know that radiation works for glioblastoma. It works in our context as well, but it specifically seems to work in the context of the backdrop of immunotherapy and benefit patients who have lower TMB than usually what is seen. So basically radiation or irradiation has an additive effect over immunotherapy, especially for tumors which are not supposed to do well, that is tumors with relatively lower TMB. So I will be talking about more of these combinatorial therapies on a session on the 30th, and I welcome you to join that as well. But just to move on from the story of gliomas to what we are learning about other tumors like medulloblastomas. Medulloblastomas were initially considered rare in the context of RRD, but now we have an emerging cohort of more than 30 patients. And what we are learning very briefly, and I can't go into too much of details, is that these have very premature cell of origin. And though they have some characteristics of the SSH subtype, they do not usually originate from the granule cell precursors. And because of the hypermutation, they accumulate mutations of both the SSH pathway as well as gliomas. And so they are some sort of hybrid entities that we see don't actually classify using either nanostring or methylation very well. So the crux, or why should we know this, is that this includes patients with P53 mutant SSH medulloblastoma, which would have probably been a death sentence. But if they arise in the backdrop of CMMRD or RRD, they can have hypermutation, they can have immune infiltrates. And this particular patient who progressed multifocally after SGMB12, after use of immunotherapy, the disease disappeared, and we are now stopping immunotherapy after 2 years of treatment. And we have a enlarging cohort of patients where we are seeing this advantage of using immunotherapy in the context of germline RRD. So just to conclude, we sort of wanted to share that high TMB and high MSI, the immune microenvironment is important for immunotherapy response. And we see survival in patients who would have never survived before. But more importantly, we are becoming aware of unique response trajectories, including the initial flare as well as delayed responses. And that's where Liana's talk about biomarkers and emerging biomarkers will be so important for us. And we are also learning that there are non-glioma hypermutant cancers which have unique biology, like the medulloblastoma story that I told about, but there are other tumors that we are learning more about. And these can also respond to ICL, provided we diagnose them on time. And that's where Brian's tool is actually going to be very helpful in the future. Thank you, everyone. I hand it over to Leanne. Yeah, sure.
So first I want to ask if anyone in the room has any questions. Feel free to raise your hand. And then we do one in the chat. Okay, so the question in the chat is, how do I know if it's flare or progression?
So a very important question, and I don't think we have the right answer, and there are only indirect indicators because no radiology sequence right now actually can say it with absolute certainty that it's flare or actually true progression. And even in the context that we saw that there can actually be true progression because flare is not supposed to happen for 4 months, right? So that is another challenge that comes up in front of us. So I think it's the biomarkers that are actually important, because if we know that this tumor or this patient has a febrile biomarkers, we should actually give time for the immunotherapy to act. And maybe even if it's flare, try to continue so that it's like delayed response and probably more importantly, prolonged patient survival.
Does spectroscopy have a role in that?
So our radiology colleagues are actually working on it, and according to them, they have tried multiple things. I know MRS is like an emerging modality, and some publications say that it works, but there are other group of people who say that it doesn't work that well. So I don't think even in the radiology community, at least in my understanding, there's a consensus of there is a definite answer of how to define pseudo versus true progression. And that's why all the trials, as you know, like do it retrospect. They say that you continue, and then if it is progressing, you say it's true progression, you backdate your progression. If you respond, then you say that it was pseudo progression. But I think that the biomarkers may actually change that in the future, hopefully.
Thank you.
All right, so thank you so much for joining us this early. I'll talk a little bit about liquid biopsy and gene expression profiling in IRRD cancers. So I worked under the Hawkins Translational Lab together with Cynthia Hawkins. And the work we do in this lab is basically developing clinically applicable tools. And many of these you will be familiar with are already clinically implemented across other brain tumor types, such as gliomas, medulloblastomas. And the goal of this lab is to develop cost-effective tools that are easily translatable to clinic. What I'm going to be talking about today is 2 of the tools that we've been currently working on and we think can be very useful in the IRRD space. So some of the issues we would like to address is how can we better predict responses, responders versus non-responders? How do we monitor response and recurrence? Can we identify combinatorial therapies in a molecular guided manner? So Anirban showed you the success of immunotherapy in IRRD tumors with a survival of about 40%. So how do we identify these patients that will truly benefit from this and which patients will require additional strategies? So he showed you that tumor mutational burden matters. He also showed that the immune microenvironment has an impact. So what we proposed is to use a nanostring RNA panel that includes 120 genes to evaluate the immune microenvironment. So what we have in this panel is 18 genes that correspond to a previously published tumor inflammation signature and additional genes, including important immunotherapy targets. So we can evaluate all of this together in a cost-effective manner. And as you see here in previously published studies, that responders had a higher score than the non-responders. So when we look at across brain tumors types, and the way we do this is we get the surgical sample. One of the advantages of using nanostring is that we can use paraffin samples. We put them through a bioinformatic analysis pipeline, and then we generate a clinical report. So when we look at this inflammation signature across brain tumor types, we can see that there's a large spectrum within each tumor, including low-grade gliomas, high-grade gliomas, and here are the MMRDs. And one of the things that I want to call your attention to is that generally it's not particularly higher in MMRD high-grade gliomas versus our non-MMRD gliomas. However, there is this spectrum of high to low, and I think this is the importance to identify here, the high inflammation scores. And when we look at the embryonal tumors, we see sort of the same pattern. However, when we look at high inflammation scores versus low inflammation scores, we find a significant trend to better response in those patients with high inflammation signatures. More importantly, the combination of these predictive factors may be the way to go. So when we look at tumor inflammation and tumor mutational burden, they don't correlate. However, if we look at these groups together, the one that has better response are the ones with high tumor inflammation score associated with high TMB. And the ones with high TMB in green and low inflammation scores don't do as well, which is a group important to identify. So how can we better predict responders versus non-responders? We believe that combining all of these tools that we talked about will be the way to go to better predict response in these patients. And how can we monitor for response and recurrence? So I'm going to talk a little bit about liquid biopsy as a tool to monitor disease. And what we do here, we use some of the strategy that Brian talked about using low-pass whole genome and panel sequencing, using ctDNA extracted from cerebrospinal fluid. We create libraries that can be used for these two strategies. So from the same libraries, we do deep sequencing in a very small panel, and in parallel, we do low-pass whole genome, which means that for the selected genes that we have on the panel, we sequence up to 20,000 times, and we're able to detect SNVs, point mutations, and fusions. And we sequence at very shallow depth, around 1 to 3 times the whole genome. That enables us to detect copy number alterations and signatures. So I'm going to show you a cohort of pediatric gliomas, and these are mainly non-MMRD. And we've had around 70% sensitivity in this cohort using the panel strategy. To show you how this can be used across IRRD tumors, this is a patient, an IRRD patient with a high-grade glioma that had CSF collected and liquid biopsy done at the time of progression. So we can see that the tumor had a copy number pattern that is comparable to the CSF seen below here. And we find multiple mutations that even may be targetable. And most interestingly, I think, is we can actually look at the MMRDness score that Brian presented earlier today. And our patient with MMRD is here with a high score together with the tumors, the MMRD tumors, while patients that are MMR proficient are here with a lower score together with tumors that are MMR proficient. And additionally, can we identify combinatorial therapies in a molecular guided manner, and can we use these tools to do so? So Anirban mentioned the combinatorial therapies using MEK inhibition and immunotherapy, and he'll have a talk about this later in the conference. And here in this paper, you can see that a lot of our MMRD tumors are enriched for RAS/MAP kinase mutations, which led the prediction of immunotherapy plus a pathway inhibition, in this case, MAP kinase pathway. What we're proposing is to use a similar strategy to the immune panel that I show. It's an also nanostring panel that looks at RAS/MAP kinase expression and PI3 kinase expression. And when we look specifically at the MMR tumors, we see that there's a range from high MAP kinase activated tumors But most importantly, the PI3 kinase pathway is also high in a lot of these patients, which leads us to believe that there's other paths and other pathways that can be inhibited together with immunotherapy to improve response in these patients. And this is a way that we can try to identify them. Additionally, when we use liquid biopsy, as I showed in the previous slide, we can find mutations that are targetable. So here you see this patient has an PDGFRA and an FGFR alteration. These are also manners that you can monitor with repeat CSF sampling, the response of the patient as you see these alterations going down. And you can also identify new alterations that would potentially guide you to add new molecular therapies. So in conclusion, the inflammation signature predicts response to immunotherapy in MMR tumors, but more importantly, the combination of these strategies would better identify responders. Liquid biopsy using CSF is valuable to diagnose and to monitor these patients. And pathway analysis can also be used to guide us in combinatorial treatments. Thank you.
Does anyone have any questions for Leanna? Anyone here in the room?
Yes.
Go ahead.
So, that's the conclusion piece, the third point in conclusion. Liquid biopsy or as a CCIB is approved in replication deficient patients. What makes it particular for this patient? There's a lot of work on liquid biopsy and CSF to DNA in general for all brain tumors.
Certainly.
What is specific for replication?
So I think there's multiple strategies. Here, what we're using is the tool that Brian developed to look at the MMRDNS score. So we can do both the MMRDNS and the Paulinus score using the low-pass whole genome in the CSF. We can also detect specific mutations. So using the panel strategy, you can look for specific driver alterations in the context of IRRD.
Yes, well, as Brian mentioned, he can do this even on saliva.
Exactly.
So
exactly.
Why we go to CSF?
You're completely right. I think what we're trying to look at is to see whether active disease will have higher scores, and that's what we believe than MMRD patients that don't have tumors. And associated with that, we look for the specific mutations that may guide us in terms of monitoring response, right? The combinatorial mutations that happen, and those you can monitor.
Yes,
you're absolutely right.
Yes,
yeah.
okay.
We have time for one more. Is the TIS score being used clinically?
So we're finishing validation for the TIS score right now. We expect to have it clinically validated by end of year, around December. And the goal with both of these tools is to have them clinically implemented and available to the group through the IRRD Consortium. And also, if locally you have an interest to develop these tools, we're available to consult and help you do so.
And if we wanted a TIS score pulled, do we need to send in patient samples?
So at this stage, it would be sending a sample. If you have nanostring in your center, we are able to share, the strategy. The TIS score is a published score that was developed using RNA sequencing in adult tumors. So I think I have the reference there as well. So you will also find it that way, but we're happy to help.
Thank you.
Thank you.
Okay, so like I said, I'm going to circle back really quickly before we throw it over to the panel. I know we've been talking for a lot, so I will make this quick and then we can have some good discussions. So you've heard about all of the work that we're doing at the consortium, and of course, we're using patient samples from all over the globe to try and accomplish all of these research goals. So if you wish to register a patient with us, you can do so by reaching out to any of the members of our leadership committee here. And I've provided some of the direct contact information over here as well. If you forget all of this, our website also has information on how to contact us. And so you can reach out to us then. So one of the things I want to emphasize, okay. One of the things I wanted to emphasize is that we are here to consult, even if you don't want to send biological materials to the consortium. So if you haven't worked with us before, here's a breakdown of the process. So of course, if you suspect a patient has IRRD and you want us to consult on it, review MRIs, this can be sent to us and would be more of a clinical consult. We may also be able to do things like pathology clinically and not in the context of our consortium. But if you do decide that you want to register the patient with us, the first step is to get patient consent of sharing clinical information and biological samples. And then what we do is we work with you to ship the samples to us. And so I want to emphasize that the consortium does cover the cost of shipping because I know that's really important in a lot of areas. We can then perform testing and consult on patient management in our rounds, and all of this information is returned to the healthcare providers. A lot of times we do these things in parallel, but again, if you just want a case consult, please still reach out and it might be something that we can do for you as well. And so just before we throw it to the panel, I want to conclude with what's next and what our next goals are. So our group has already made a lot of progress on the development of innovative diagnostic tools, and that's what you heard from Dr. Chung. We've done a lot of work on early detection and surveillance. We know that surveillance greatly impacts survival of patients. We've done some work and continue to do additional work on novel and combinational immune-based therapies. And so now we're looking at what's next. And for us, that's prevention of cancer. And specifically, we're working on a cancer vaccine project. We recently got funding to work with some of the people who helped develop the Moderna COVID-19 vaccines. So we're really excited about this. We have a lot of replication repair deficient mouse models that we can test these vaccines on, but we can't do this without your help. And in order to be able to identify replication repair deficient specific tumor associated antigens, we need SNAP frozen tumor tissue from patients with IRRD. So if this is something that you're thinking about contributing to our bank, we can use it for this project, and we think it'll be really impactful for patients. And so I just want to conclude by saying that, all of these tools and these insights you guys have helped us develop and you've helped us recognize. And really what we want to do is help you implement all of these things, whether it's surveillance, logic, tumor immune scores at your centers. And so that's something we are working on as well. And we're working on in parallel with other centers to implement logic, for example. So if this is something you want to discuss more, please reach out to us. Okay. So thank you to all the speakers. You guys did a great job. And Eric, we're going to throw it over to you for the panel. Just for the panelists, please make sure you're speaking into the microphone for the ones that are here, because that's how they'll hear you over there. And Lucy, I'll let you take it over because we do have two panelists at home and we're going to pin them to the screen here and I'll let them introduce themselves as well. So we'll get that set up in just a minute and we'll throw it over to Eric. Thank you guys.
Yes, so thank you. And so I would like just to spend more time to introduce the panel, but time is the driver here. And without any delay, I want to give the microphone to Dr. Kubudi because she's going to lead. So, and the aim of the panel is essentially to bring people from countries where there is a high prevalence of CMMRD and to hear the message about, what are the perspectives, because at the end, all this work is done to help and support patients and families. But things have been organized and they work beautifully. There are, however, some challenges, and particularly with regard to access to treatment. So we want to hear first from you, and then we will move a bit slower when we talk about the other party.
Thank you, Dr. Bouffet. First of all, thanks to all our speakers today. We heard very nicely of what has been done and what are we doing in low and middle income countries. thanks to Dr. Bouffet, Dr. Tabore, and all the team that we had the low and middle income country panel in that at SIOP some years ago. And at that time, we did a position paper to increase the awareness in low and middle income countries, which is very important. I think this is the first step to increase the awareness that there is something like mismatch repair deficiency, and that we can diagnose these patients and we can cure these patients, as has been said with immunotherapy and other some modalities. That was the first step. And the second step in the position paper was that even in low and middle countries, the first step should be to be aware and do immunohistochemistry, because you can, that has been shown, most of it, like 86% with the immunohistochemistry at least, then you go on with the further testing. And thanks to the consortium that this can be done free of charge, even with the transportation. There are some problems sometimes, like we had sent samples and they came back from the Canadian border because the customers not let us in. So there has been some problems that we want to overcome those problems. The thing is that we have the consortium, and that's a great tool. So when we have a problem, we can always discuss with the geneticists and all the doctors and the other team to make the diagnosis and to cure these patients. I think my other colleagues, the stream and Doreen, and you will be talking about more of what has been done. Increasing awareness, I think, was the first step. And because of that, we are diagnosing more and more patients. Thank you. I'm sorry, I have to open another session. That's why I have to run that.
Okay, so I don't know who is online or not online, so we will just move bits.
Dr. Bouffet, we do have Dr. Girish Kinnaswamy from Tata Memorial Hospital, India, and we have Dr. Nisreen Amahiri from Jordan. Dr. Noreen has joined, or probably not joined, and we have Motassam as well.
Okay, so we can also hear from Motassam to know what is the perspective in Egypt. I have the feeling that we don't know very much about the prevalence of CMMRD in Egypt, and I wonder why, whether it's because patients are not systematically tested, because as you could see from the slide, you can have a variety of tumor. 44% are glioma, but there are kidney tumor, there are bone tumors, there are bladder tumor. So I think my question is, do you systematically test your patient for CMMRD? And if not, why?
Okay, thank you, Eric, and thank you everyone for having me today. In fact, yes, I totally agree with you. We had, until a few years ago, the term of mismatch repair was not that comprehensive for us. It was not that common. A differential diagnosis, unless you are faced with a striking family history of malignancy, and even in these cases, the first thing you think of is leukemia or something like this. So until very recently, despite we have, of course, high rates of consanguinity, and expectedly we should have a high prevalence of CMMRD in our patients. But to be honest, this has largely improved over the past few years, and in part this has been thanks to the consortium and the tumor board that we have been doing with you for many years right now. Yes, it helped to increase the awareness. And another thing that it originally came from the new oncology, so that's why we have been always focusing on glioma patients. But like you mentioned, I see many cases that only we diagnosed after second tumor, like a glioma, and they have been previously diagnosed as lymphoma or other tumors in pediatric that was not, or even colon cancer that did not attract the attention to investigate the presence of CMMRD or not. So we have initiated some efforts to screen for at least in the Children's Cancer Hospital where I work, as you know, and we are the largest center in Egypt. We receive, I can say we receive like 70% of the burden of pediatric cancers of Egypt. But still, we aimed high, we aimed at having a screening for the patients. And once they proved, we start to screen their siblings, yet we were held by the costs, the logistics. And that's why we are really interested in the logic. If we can make it something that's really cheap and affordable, yes, it will definitely help in such initiative. But so far, we're doing a targeted sequencing for certain panel of predisposition genes, including the mismatch repair. What we initiated recently also is that the routine immunohistochemistry staining for all gliomas in young adults, especially PXAs, and all we were adopting a similar clinical criteria. You know, the Care for Cancer initiative, Care for CMMID initiative, European-based. They have this scoring system, and if a child scores more than 3, then it should be screened. We try to adopt this in our patients retrospectively. But as you said, we don't still, until now, we don't have a true indication about the exact prevalence of CMMID in our patients.
So do we have our speaker here? Yes, hi.
You have Garish and you have Rizrain.
So can we, hi Girish, I'm not sure that you are in Mumbai today. And
that's right, yes.
We miss you here, but you are more than welcome. Can you comment on the same topic, which is what are the challenges in diagnosis CMMRD? Because certainly India is a country where there must be a prevalence. You know, I don't want to teach, but 20% of the population is named Patel. So it suggests that, you know, there are consanguineous marriage in your community, whether it's the Hindu community or the Muslim community, and how do you deal with this in your daily basis?
Yeah, thanks, Eric. Can you hear me well?
Yeah, very well.
Okay, great. Eric, as was already mentioned, that there was lack of rather awareness about CMMRD for a long time in the oncology community itself. So we did treat a lot of glioblastomas and a lot of second malignancy, and we did not actually think about CMMRD in the beginning. However, in the last 5 to 7 years, after the consortium has become very active, there's a lot more awareness now. And we have a clear guidelines on whom we would test for CMMRD. So if there's a family history of, say, GI cancers early, if it's a second malignancy and it's a glioblastoma, say, or high-grade glioma in a child, we have a low threshold for testing for CMMRD. And we actually started off by doing the immunohistochemistry. And just to tell you, in the last 6 or 7 years, about 78 brain tumors which we tested for by immunohistochemistry. 31 children had loss of function, suggesting of mismatch repair proteins, so suggesting that they had CMMRD. Now we actually got a comprehensive cancer predisposition project where we would actually screen for high-risk patients, and CMMRD is included in that panel. And we are now using a 96 gene panel of Illumina TrueSight to test for them. In that, all brain tumors, glioblastomas would get included, all second malignancies, consanguinity would get included. And of course, if you have a clinical phenotype of a CMMRD or Kerfeole spots, or even if you suspect it is NF1, you would go ahead and do the panel. And so now we have started picking up in the first malignancy itself. Otherwise, a lot of them we picked up previously in the second malignancy. They got treated for leukemia first, and then they got glioblastoma, and that's when we started hunting for CMMRD, and that's what we saw. Obviously, in the Indian population, there must be a lot more than what we are seeing, but because we are not having a easy way to test for it across all oncology centers, it has been not picked up so far. But we think that with projects like this and with awareness like this, it will increase.
Good. Thank you. And Ms. Rain, good morning.
Morning.
Welcome in Barcelona. So you are in Anan at King Hussein Cancer Center. Can you comment as well on how do you diagnose and what you published the first paper which really showed that you have a massive number, proportion of your patients with high-grade tumor, 40% or 49% had CMMRD. So how many do you see, and do you stain for CMMRD any patient or only brain tumor patients?
Good morning, everybody, and thank you for the invitation. Do you hear me well?
Yeah.
Okay, great. Thanks for this webinar, and nice to see you all. I hope you are enjoying Barcelona. So yes, as Girish said and Marta said before, I think we do have a good proportion of patients with a mismatch repair in Jordan. So after that retrospective study, which we did, we started to screen all our glioblastoma or high-grade glioma patients at the KHCC, and KHCC does see about 70 to 80% of children with cancer in Jordan, so we see the bulk of patients. And then we also screen those patients who have clinical criteria, and also some medulloblastoma patients as well. I think we do capture most of the patients with brain tumors. However, we do miss patients who have solid tumors and leukemia and lymphoma cases. Most of the time, we pick these with their second cancer or when they have significant family history. So I do have patients who have families with more than one sibling now with mismatch repair. So we know this for a fact. So when another child presents with the same scenario, we do pick these families. So we probably do miss a lot of patients with other than brain tumor diagnosis. How do we screen? It's the immunohistochemistry basically. So we think we do capture like the 85–90% of the cases. And those who have strong indicators like family history, capital sports consanguinity, we do recently started to send genetic testing for them because we just recently implemented the pediatric cancer genetic clinic. What challenges we face? I think the main challenge is the fact that we are talking about a genetic disease. So this is still thought by the families to be as a kind of a stigma from one point. Despite that, I have several patients with a diagnosis of CMMRD. We never had cascade testing. So these families, though they knew they had a genetic mutation and they have a child with a tumor or a brain tumor, they did not test their other siblings, or they did not test the father or the mother. And in fact, I have a child who her mother was diagnosed with a metastatic ovarian cancer, and she died, despite that we told them that they are, by default, they have Lynch syndrome. So I think this is the most challenging part regarding the genetic testing and the implications of the results that we give them. And the other one is that, that the family exhaustion, when they come with a tumor and then you treat this tumor and then they have another tumor, then the third tumor, they feel they are really exhausted, and this child is really suffering and the quality of life is not perfect. So they end up, losing hope with success in this battle. And also, we have to talk about also cost of this therapy on a low middle income country scale, that you keep treating these patients with several cancers. So I think these are probably the top three challenges I think I face when treating these children nowadays. We did use the immunotherapy in KHCC for these patients. I think I've treated around 6 patients. Unfortunately, 4 of them did progress. We did not go to the second line, or 2 of them did go to a second line, which is re-irradiation. And 2 other patients are still on therapy. Our treatment was pretty much good without much side effects, but this treatment is not going to be maintained now because we were using this through a compassionate access. However, if we will now pay for these drugs, it is really high cost. And the last patient I treated just recently, the cost estimate was really high, and we have to take approvals to use these medications. So I think this is the major challenge that's going to be in the near future.
Thank you, Nisreen. So we will talk about the treatment a bit later. So I just was in touch with Dr. Mushtaq, and she's going to join. She's finishing her round.
Yes,
Okay, so Noreen, good morning. So you are in Karachi. It's 40 degrees, I'm sure, already. And the question to you this morning was, so how do you diagnose your patient? Do you have a systematic approach, or just do you identify by the background, either the clinical presentation, the type of tumor, the consanguinity, or do you have a sort of systematic staining for all your patients at your institution? Because you see quite a lot of patients with CMMRD at Aga Khan University and around the country as well.
So thank you, Eric, for your question. So we are diagnosing our patient on the basis of the clinical manifestations, the history, the eye examination, and then for the last 3 to 4 years, we have started doing the mismatch panel through our immunohistochemistry, and we are doing all we are checking these markers in all of our high-grade gliomas patient. We have also tried to start doing these markers on T lymphoblastic lymphomas, colorectal cancers, some of the neuroblastomas and other solid tumors in which we are suspecting CMMRD. So this is, and then once a patient is diagnosed with these markers, so we will send, we are usually sending samples to the consortium for the further genetic testing.
Good. So one of the issues I wanted to address, and I know Anirban, you sent the survey around, and we are interested in having your feedback regarding this survey, because there are very important question is, once you have a patient who is diagnosed with CMMRD because of your staining, what kind of challenges do you face in terms of genetic counseling, discussion with the family? Is there a sort of taboo here, or do you have some issues in dealing with this condition, which apparently is throwing a stigma on this population?
Yeah. So that's a very good question, Eric, because many of our families don't want to do these genetic testing because of the label they will have after diagnosing the CMMRD. So out of my 50, 60 patients with the CMMRD, majority parents don't want to go for the genetic testing because of that stigma. It's not only with the CMMRD, but it's actually in general, like for leishmania, for even other genetic disorders. So families don't want to do these testing. So it's kind of, it's a very, very big challenge for us to counsel them and, to let them do these genetic testing, because it's very important for them. And it's like previously I was thinking maybe it's not that common, but somehow over the last 3 to 4 years since we have developed this capacity building with the other centers, we usually have 2 to 3 patients in every tumor board, which are suspecting cases of CMMRD. And it's only brain tumors. So we have actually no idea what sort of lymphomas or maybe other cancers we do have with the same syndrome. So it's not uncommon in our part of the world.
Good, and can we have the same comment from the other panel member, from Nisreen? Can you comment, and then Girish and Moatassem?
Yes, I think I second what Noreen said. I think the genetic stigma is really there. It's again, it's not only for BMMRD, it's for all genetic types of diseases. But I mean, the families are now taking the first step. So they agree to, my patients at least, they agree to take the first step to test their child, but they don't go beyond that. Like the second step to go into screening for the parents because they are obligatory Lynch syndrome, or to screen other siblings. I did not encounter any patient now who's doing that. And yes, you can anticipate the stigma that I had that child with a lymphoma and not BMMRD, and they were two very close relatives sitting in the same ward in the pediatric department, and they don't want each other to know about the other siblings. So that's how much the effect of genetic testing has on the community, because all these families are married to each other, and it's a closed community, and so they can easily talk about this in their small community.
Yeah.
Girish?
Yeah. Eric, it has been better now than it was, say, 5 to 10 years ago about testing rest of the family members. So out of the 30 plus CMMRD who we tested in high-grade brain tumors, whom we had genetic testing done as well, 18 families actually agreed for testing, and we actually found 17 of them having families having, it's a family of CMMRD. So in about 10 of them, I think both parents agreed to test, and we tested them and they were actually carrying them. And in about 3 of them, only single parent agreed to test, and in others, only the siblings were allowed to test. So we have got a mixed response, but it is better than what is before because of the, I think we have a reasonably better cancer genetics counseling now than it was before. And that is helping a lot because they are actually re-stressing the point that if you actually pick them up early and put them on surveillance, then they actually can pick up the tumors early and treat them better. I think that's helping. So about 60%, I would say families are agreeing for screening if you have a proband with CMMRD.
Yes, I tend to agree with all of them, but another aspect that I face is that how they perceive the fact that this is multiple cancer probability or the likelihood of having another second or third malignancy. This is really devastating for the families, and sometimes this is, I think it was a sort of denial. They don't want to believe that they are already suffering or struggling to fight this present cancer, and they are hoping for cure. This is the end. So when you tell them no, when he gets older, he can. But again, and when we try to calm them down, saying, but don't worry, there's a promising hope for immunotherapy. And they say, is it available? And we say, not really. You know, this is part of counseling that makes them, when you get their hopes very low this way, they are not motivated to go for any further steps for even with healthy siblings. So we need to put this into consideration as well.
No, and so this is going to be a fascinating story because of the comment that we heard, regarding vaccination, for example. So because this may change completely, the story of CMMRD, and this is where the research is fantastic. But my question regarding the diagnosis is also about, will the diagnosis help outside the fact that it can lead to surveillance, but does it really affect your management of the patient, or it doesn't affect? Because all the big question is, do you have access to immune checkpoint inhibitor? If not, there is really no real benefit in terms of clinical management. So can you comment on this? And I would like to hear from each of the panel members.
Yes, exactly. This is how the discussion with the families goes. So what do I get if I know that I'm having a CMMRD, or the siblings of my child are also having CMMRD to screen, and then how would it differ in the management? So we explore all these points, but at least we say, knowing that there's hope. Sometimes I tend to tell them, think about it differently. Your high-grade glioma is relatively better than the normal high-grade glioma. Indeed, it's a glioblastoma. It's progressing, nothing to be done. At least there's hope. Yes, it's not available right now, but it would be available in other centers. We can seek compassionate use or something like this. I try to give them the brighter version of the picture. But yes, in general, we do manage them all the same. Although sometimes we are more keen. I don't know if this is me or my colleagues as well, but I feel more keen on the CMMRD patients because I believe they are special category that was further attention rather than the other patients. In this context, they can benefit from immunotherapy, so I can fight for it. They can benefit, like, for example, we give them now temozolomide with radiation. I believe they are different, so I treat them differently. But despite the fact nothing, no concrete facts that is really different in the management right now, but there's hope that it will be a different story in the future.
Thank you. So, yes, I wanted to know if there is any question from the audience. So, Charles Lab.
Regarding the availability of immune checkpoint inhibitors, may the dosing question help because the target occupancy dose is much lower than the recommended official dose in SPC. Can this increase the availability of the drug?
You want to comment, Haniaman?
So we have sort of used some dosing strategies to make sure that it is more feasible. For example, we have sort of moved over to 6 mg per kg every 4 weeks instead of 3 mg per kg every 2 weeks for nivolumab, because that has been shown to be equivalent in adults. But I'm not sure that if we reduce the dose, so that has been done anecdotally in some of our patients in the consortium. They could have probably relapsed anyway, but right now we are not reducing the dose based on the data that you mentioned, but rather than using the same dose at a larger frequency to make it more feasibly administered in all settings.
So, Eric, if I can comment on that, I mean, I think that's a very important point which we should address, is that is 3 mg per kilo the right dose of nivolumab? Because as you know, there are a few papers which have come out telling that 70% of the T cells PD-1 saturation can occur at even 0.3 mg per kilo. And then whether actually 3 mg per kilo is truly required, because as for immunotherapy, developing a phase 1 dosing on a dose limiting toxicity may not be the right thing. By the time you reach the high level dose, the actual efficacy dose might have been much lower than that. And there is some data from the adult side. And in fact, we just did a randomized trial on the adult head and neck cancer, which was presented in ASCO this year on low dose nivolumab. And it was shown that it worked clearly in a randomized fashion too, though it was only up to 18 months follow-up. But nevertheless, the difference was quite dramatic. So my question to you or the rest of the panel is that, is there any scope to actually look into that aspect? That do we actually need to give 3 mg per kilo? Because the impact of that on the low and middle income country is huge. So just to give you an example, we did a survey on about 15,000 adult patients who would have benefited from immunotherapy, taking into account everything, non-small cell lung cancer, GI cancers, everything. When we did a survey, we found out that in India, only about 2.8% can actually afford the immunotherapy with the present dosing. But if it is actually the dose can be reduced, and if you can prove that the efficacy is equivalent, then actually substantially larger number will be able to take this. So is there a scope for discussing that as the adults are actively discussing at the moment?
No, I agree. So this is an important question. So we certainly need to address this with the lab people. When you were talking, it reminded me some discussion about, CML and imatinib, where, when you look at now 20 years of experience, in fact, the data on imatinib suggests that you can reduce the dose, in fact. And initially, people were pushing the dose up to 800 milligrams per day. And now some people say, no, you can use 200 milligrams per day. Over 20 years, it works. So it's just all about what is your objective. Do you want a quick response, or do you want just to go as long as you can? And we have used so far, at least in our protocols, the standard dose of treatments. We have moved recently to the extended administration every 4 weeks for nivolumab, every 8 weeks for pembro, every 6 weeks for pembro. But this question is important, particularly in the context of the difficulty to access this medication in countries with limited resources. Nisreen, do you want to comment? You have an experience, but you mentioned that your experience is more negative. So I think this is a very important topic to address. It's just, why is it negative? Can we dissect this, and can we look at the reason for? Because one of the questions is, are your CMMRD patients the same as the one that we see in our countries, where CMMRD is either, I always say that to Uri, they went on the same ship when they came from Ireland or from France, and then they settle in the same village, and that's how consanguinity rose. Or they came from background of community where consanguinity is part of their culture. For example, the Muslim community, we see a number of CMMRD patients who have a Muslim or a Jewish background, but that's not always the case. So, but it may be that the profile of CMMRD may be different in your country to explain that you have this different response to immune checkpoint inhibitors.
So I'm not sure, Eric, if it is just a different population or it's that we don't usually go to a second line. So, so at least from the 6 patients I've treated with immunotherapy, I can say that the first experience was not really much of a success because we started on a larger tumor burden. So I think the patient became very symptomatic. So we were afraid this is our first time to use this treatment. So we just held the treatment sooner than we should probably. That's something we knew by now. And unfortunately, he passed away. There are 2 other patients who really did progress. And then we just stopped the immune checkpoint inhibitors, and then they progressed further. So we gave radiation, and they're still doing fine. So, and there are 2 other patients who passed the first year of their treatment, and they are in complete remission. So I don't know. It's probably that we also don't go for a second line treatment after the first. After the second progression. Which is something also Marcus alluded to, because these families really they feel that they are exposed with frequent tumor progression, second cancers, and all these things. And also I think the health system as well becomes exhausted, like with the patient with recurrent progression, recurrent admission, recurrent hospitalization. So all these discussions about what is next. So these patients probably will have several cancers in their lifetime span. How is their quality of life? They're missing school. Their families are missing their work. So all these discussions go in the background discussions with the families. So probably again we're not in the. I use nivolumab and pembrolizumab, but we did not go, for example, to use AP, for example, or we did not use the MEK inhibitors for these patients. So we did not go and take the second step after further progression in immunotherapy. So probably that's why our survival also is on the low side. But again, we did not do detailed genetic testing in these patients, so we don't know if they are really different from Sept's cohort or not.
Thank you. Noreen, any comments regarding the impact on the management of your patients?
So, Eric, we don't have nivolumab previously, but for the last few months, there are companies who are selling and giving us the nivolumab, but it's extremely, extremely expensive. So I haven't used nivolumab in any of my patients, but for the high-grade gliomas, what we usually do is the same protocol with like the radiation and the CCNU. We are not giving temozolomide in our patients. But we are trying, like in our next patient, maybe I can try nivolumab, but our patient need to buy from their own pocket, and it's around $1,000 per dose if you buy it here in Pakistan.
Yeah, so I think this is one of the challenges, the need to work and so maybe I know that now we are running out of time, but looking at the drug company that may help here, one is certainly an interesting because they have already initiated some work in low and middle income country. This is Roche, but they are making a PD-1 inhibitor. So what would be the risk here, Anirban, just to switch from nivolumab to atezolizumab?
So the problem that we face is that the PD-L1 is expressed on the tumor cells, and the PD-L1 molecules being monoclonal antibodies don't go into the CNS that well. That's why we have had experience better with anti-PD-1, where the thing happens peripherally and then the T cells probably are more effective inside the CNS. So that is hypothetical to some extent, but that is why with our anecdotal experience, we believe that anti-PD-1 will probably work better than anti-PD-L1.
Sorry, so I mixed up. Yeah. So so far you are more supportive of Nivo and Pembro than any other compound.
So yes, and partially no, because we know that anti-CTLA-4 at the failure of anti-PD-1 works, and there are other checkpoint inhibitors that we are trying in our mice models that are actually showing promise, but not as single agents, but in combination with anti-PD-1. And in adult cancers, those are coming in as well in the clinical setting.
Jaroslav?
Just a follow-up question. How much is known about other potential targets, expression of LAG3, TIGIT, IDO1?
So that is again something that Liana and our team is looking into, and we are finding, again, this is like unpublished data, that there is probably an upregulation of TIGIT. So we are in talks to see that whether anti-TIGIT plus anti-PD-1, even anti-LAG3 plus anti-PD-1, and we are doing these trials right now in our mice models, and hopefully we'll see some early signs of success to move early into humans.
Okay, so we need to conclude. I want each of you in 1 minute perhaps make a comment about whether you have implemented surveillance in your countries.
Yes, we have the initiative, yet the testing part is what is challenging, because we opted for NGS targeted sequencing, and we got stuck with the finance. So we did screen some of our patients, a decent number, and we were hoping to screen the families as well at the next step or next phase of the project, but we could not go on because of lack of funds.
And what about MRI scan and regular surveillance testing?
Yes, we proposed this, but we did not implement yet, because once we started to be aware of the lack of funds. We don't need to exhaust our resources in surveillance now. It was like, this was a hospital initiative. It should be a governmental initiative. This was not the case. We initiated it as doctors in our hospital, and we managed to convince the board of the hospital, yes, we should go for this. But then they got back and said, no, this is too way much for us to do, because we were suffering from other resource challenges, even for the normal treatment process for other children with cancer.
Girish, a comment on surveillance?
On surveillance, I think screening once we have a patient and actually identifying other family members is only one step. I agree fully that surveillance is a much bigger logistical exercise than that. And especially because our patients are all over the country, to actually keep them on track and do it is becoming very difficult, including the Leaf Romini family who we have, or some of the CMMRDs. We are not able to actually logistically do a very systematic surveillance.
Okay, so that's important to know, because we need to work on trying to see how we can implement Nisreen.
So for the patients themselves, we do only upper and lower endoscopy. That's like routine, because patients just continue to follow up like HCC. Other family members or parents, no patient initiated this, so we did not really look into the logistics of testing the parents or the siblings. I mean, financially and from resources as well. So for the patient, it's covered by the insurance for cancer.
Lucy, can you hear us now?
Yes, sorry, you did not hear us?
We can put the mic here.
Okay. So I said that for the patient, we initially do the PET scan. They're just at diagnosis, and then we also do upper and lower endoscopy, and we do this on a serial basis because the patient himself or herself is covered for the cancer treatment, and this is considered as part of his follow-up at KCC. That's the only surveillance we do, upper and lower endoscopy. For other family members, no family said that they will do the genetic testing, so we did not really check into the logistics of testing other family members, but I think once we do that, we will have the same problems. Is it covered financially? Who will pay? Where they will do this testing, and how they are going to be followed? So this is going to be really logistically more challenging.
Okay, and Noreen, for you?
So Eric, we are in the process of developing a simple form for our collaborating centers and our centers And we have included the CBC basic tests like chest X-rays, MRI. And I think we'll be able to do that. But the only issue is the colonoscopy, because some of the centers has this colonoscopy units and all those things, gastroenterologists, but many centers don't have any. So we are in the process of develop this. I hope at some point in time we will have like national guidelines of our patients for surveillance.
Okay, so I will just take the microphone and thank everyone. So I don't know if Vanessa, obviously you want to give the concluding remark, but your feedback is very precious to us in terms of understanding where we go next, and particularly in terms of advocacy and maybe publication. Just try to show how much now discrepancy there is between the knowledge and the limited access to treatment, and that's where we need to build some bridge.
Hello. Okay, so thanks everyone for joining us. Sorry for any technical difficulties. I hope everyone joining virtually was able to get through all of that. But yeah, I want to thank you once again for joining us on behalf of Dr. Bouffet, the Replication and Prayer Deficiency Consortium, and our fantastic panel of experts. Thank you again. We're really doing this for you and for your patients. So it's great to have feedback and realize where the holes are and what work still needs to be done. And I think we have some more ideas now about where to go. If you're interested in getting in contact with us regarding an ongoing clinical case or a scientific collaboration, our contact information is available on our website, replicationrepair.ca. And that will take you directly in contact with myself or Vanessa, Anirban, or Uri, or Eric. But we would invite you then to please have some food and some snacks. And I think Eric is about to go give another talk now on brain tumor management. So you can follow him down the hallway. And
right.
Yeah, for the rest of you, take care and enjoy the rest of the conference. Thank you.
Thank you. Thank you.